Good morning, everybody. Welcome to the ninth session of our Cerebrovascular Q&A. Remember that these episodes are both streamed and recorded in the Seattle Science Foundation channel of YouTube, so you can access them anytime and also the previous sessions on demand. My name is Matthias Costa. I'm a Cerebrovascular Fellow at Swedish Neurosciences Institute here in Seattle, Washington. I want to thank SNI and Seattle Science Foundation for your help organizing these sessions and your support, and especially to Dr. McDougall, who is a great backup for any activity. Today, we have the privilege to have Professor Mossa-Basha. He's a neuroradiologist in the Department of Radiology at UW, University of Washington Medical Center, and an UW Associate Professor of Radiology. Additionally, he was recently appointed Professor and Vice Chair at the University of North Carolina at Chapel Hill. He trained at Henry Ford Hospital and later at Hopkins, and his expertise includes cerebrovascular imaging, vessel wall imaging of multiple pathologies. And his academic interest includes imaging of the both brain and spinal cord in many aspects. I truly recommend for any fellow or attending in open cerebrovascular neurosurgery or interventional neuroradiology to go over his work on vessel wall imaging specifically, which is, for me, I think it's spectacular and goes deep into many concepts that we don't usually domain. Professor Mossa-Basha, thank you very much for being with us, and you can share your screen.
Thank you so much, Matthias, for the introduction, and certainly excited to give this lecture to all of you. Okay, there you go. So I'm going to be talking to you about vessel wall imaging techniques, applications, and evidence. And as Matthias mentioned, I've been at University of Washington for the past 10 years, filling the role of Vice Chair of Clinical Operations, Chief of Radiology, and Director of MR. And I do maintain a professor title at the University of Washington and affiliation, but recently I did move to University of North Carolina, where I am Vice Chair of Quality and Safety, as well as Director of MR and full professor. You can see the sky's a little sunnier in North Carolina than it is in Seattle in general and currently. So some perks associated with that. So in terms of what we're going to talk about the background of vessel wall of vascular disease, vessel wall imaging techniques, vessel wall imaging in the setting of stroke, vasculopathy differentiation, plaque characterization, as well as aneurysms and its value in aneurysms. So first, why perform vessel wall imaging? We have luminal imaging techniques. We have CTA, MRA, DSA, serving as reference standards for vasculopathy assessment, stroke decision-making, and characterization of vasculopathies, as well as differentiation. Why do we need something new to disrupt the field and provide additional, maybe confusion in terms of what imaging should be done? So here are three cases, each with a different disease on catheter angiography. And I've shown this to a number of neurologists, neuroradiologists, neurointerventionalists, neurosurgeons to see what they thought in terms of diagnosis. And everyone has struggled in terms of identification of which disease is which. And we'll go over this in a little more detail in a little bit, but as you can see, the first case was atherosclerosis, second case was RCVS, and third case was vasculitis. Certainly very different diseases with different implications, but a lot of overlap in terms of imaging appearance on luminal imaging. And to further dig into it, in terms of luminal imaging techniques, when you look at CNS vasculitis, there's limited specificity and sensitivity for this diagnosis with DSA. The sensitivity ranges from 30 to 90%. And the reason there's a lot of variability in terms of that sensitivity and also a wide, limited sensitivity is because of its limitation in small artery vasculitis, small artery angiitis, including lymphocytic and granulomous angiitis. The specificity is in the range of 30%, mainly because of the fact that in terms of other disease states that look like it in that slide we just showed, RCVS is really indistinguishable from CNS vasculitis in a lot of cases, imaging wise, and there's also overlap from other vasculopathies, which are much more common than CNS vasculitis. And with CNS vasculitis, primary angiitis or secondary involvement, while it is very rare, it's always on the consciousness of neurologists because of the fact that it is such a difficult disease to diagnose, and also it has such poor outcomes when it's treated incorrectly or in a delayed fashion. We'll talk about that a little more in a little bit. But in terms of case series, looking at biopsy-proven cases of vasculitis, these have shown that DSA is completely normal in 25 to 43% of cases, specifically in the setting of small artery vasculitis. When we look at atherosclerosis, frequently atherosclerosis will outwardly remodel and grow outward. And in a lot of settings, it can really reach an advanced stage before it shows any degree of stenosis. And this really can significantly underestimate disease burden. There was a French autopsy series in which they looked at patients who had suffered fatal ischemic strokes and found that 40% of the atherosclerotic lesions showed minimal to no stenosis. So certainly there's a gap there, and luminal imaging is really trying to get us to where we need to be. It's just not reaching that stage. So frequently, especially in the setting of vasculitis, invasive tests such as lumbar puncture and brain biopsy are performed in order to try and clinch the diagnosis, rule it in or rule it out. But in terms of LP, this can be a really non-specific test in a majority of cases. And in the setting of biopsies, the overall biopsy sensitivity is 50%. In the setting of appropriately targeted biopsies, that sensitivity goes up to about 75%. And with inappropriate targets, that sensitivity is incredibly low. In a study of 79 patients who underwent brain biopsy at NYU, a case series, they found that there was no correlation between CSF analysis, neuroimaging, and surgical technique with the outcome of the brain biopsy results. They tried, in cases where they tried to do smaller biopsies and craniotomies, they were less likely to yield diagnostic results, and 16% of patients had postoperative complications post-biopsy. Only 11% were positive for vasculitis, and 30% yielded alternative diagnoses. So in short, pretest probability is limited. Biopsies are not a very sensitive exam. They're very invasive and result in complications, and any efforts to limit those complications through smaller surgical approaches frequently result in non-diagnostic tests. So certainly limitations there in terms of invasive tests that are considered, in the setting of biopsy, a gold standard. So why is it important for us to differentiate these vascular diseases? Treatments are divergent, and they can be very harsh and not tolerated well by patients, especially when you think of immunomodulation therapy. And delayed therapy or incorrect therapy can result in significant morbidity and mortality for patients. Vasculitis going unchecked certainly can have very poor outcomes for patients. But in addition, treating RCVS with steroids or immunomodulation will result in worse outcomes for those patients. And similarly with atherosclerosis, treating with steroids may result in progression of disease and potentially increased likelihood of future stroke events. So vessel wall MR is a technique that has been extensively used for extracranial carotid atherosclerotic disease. There's a lot of literature out there that's been accruing over the last 30 years. And in addition, intracranial vessel wall imaging has progressively been gaining data in the literature, and it's shown a lot of promise, both in terms of differentiation and characterization, as well as in other settings that we'll talk about, such as cryptogenic stroke or ESIS. So we'll talk a little bit about techniques. This is not the most exciting part, especially for those that are not intimately involved in the imaging protocols, but we'll run through it just to give you kind of a general overview. So in terms of vessel wall imaging, it can be done with 2D or 3D imaging. And first we'll talk about 2D, and this is an example of a patient who had a left MCA stenosis on MRA. And what you can see on the axial image here on this vessel wall image is there's a little focus of enhancement. But in this setting, you really can't tell, is that the vessel wall? Is that subarachnoid? Is that parenchymal enhancement? It's not really really obvious as to whether it's a lesion or not. When you do the sagittal plane imaging, you can clearly see that it is involving the vessel wall. It's outwardly remodeling, it's enhancing, it's the typical appearance of an atherosclerotic lesion. So in this setting, if you are going to do 2D imaging, which some people are still doing because of technical limitations on their scanners, it's important to image in multiple planes, not just one plane. And then with 3D imaging, you can really do a lot in terms of manipulation and visualization. You can take that 3D acquisition if it's isotropic and really manipulate it and reformat it into any plane you want, including doing curved planar reformats where you can see the whole vascular tree in one image. You can reconstruct it so that each image is perpendicular to the lumen, and we've been working on software in order to allow for that. But certainly a lot more flexibility there. And if you have the ability, it's certainly worthwhile to perform 3D imaging. A couple artifacts I do want to mention, and I'll talk about ways to mitigate these artifacts. But one thing is in the setting of vessel wall MR with 3D imaging, CSF, it can be an issue, especially as you go higher resolution, you lose SNR. What can happen is areas of CSF stagnation can look like signal. And, a lot of times kind of in these areas of crotches of MCA branches, especially M2 branches, you can get this sort of signal appearance where it looks like wall thickening, but in reality, it's just CSF non-suppression. So there are various techniques that can be used. There are a couple of techniques that we'll talk about. Anti-drive and restore are things that we build into our protocols that can reduce that CSF signal and better delineate the wall from the surrounding fluid. And so other things, one major issue with 3D vessel wall imaging and vessel wall imaging in general is the long acquisition. It's a very high resolution. We do imaging with 0.4 to 0.6 isotropic voxels. And historically, those scans were 10 to 15 to 20 minutes long. You do 2 of those in a patient, that's 20. If you're doing other things on the MR, that protocol can add up to 30, 40, 50, 60 minutes in a lot of circumstances. So that sort of scan time is not really acceptable in a lot of radiology departments that are busy, emergent patients, patients coming in and out. You really don't have time for long protocols, and that's really hampered the adoption of vessel wall imaging. So a lot of accelerated techniques have been employed and really maximized in order to accelerate things. One of them is CAIP, which is a 3D acceleration technique, a parallel imaging technique that's shown value in terms of accelerating. And what it does here is it actually accelerates from about an 8 to 10 minute acquisition to about a 5-minute acquisition. One issue with it is it does reduce the signal, right? And in that setting of reduced signal, there's increased flow, there's increased noise in the background. So with an aneurysm like this, you can see there's a lot more noise within the aneurysm sac, which in certain circumstances can mimic pathology. We'll talk about that a little bit more. But here's another case where we use that CAIP acceleration, and you can see the native acquisition has less flow artifacts within the lumen of the vein. Here there's a lot more flow artifact, and that flow artifact also increases in the post-contrast setting because contrast changes the signal of blood. So even if it's dark on pre-contrast, post-contrast, that signal can appear. So this is a study that we've had provisionally accepted to AJNR, in which we looked at 89 consecutive patients who had conventional acquisition, but also had an accelerated acquisition with CAIP. And Dante is something that helps suppress both CSF and blood flow. It does both. And so we did an acquisition with Dante CAIP or with Dante. And we compared these based on image quality. We evaluated based on quantitative metrics of signal to noise and contrast to noise. And in looking at these, looking at the Dante CAIP, which is the accelerated and blood suppressed technique, it was better in all qualitative metrics except for signal. So the signal was a little lower than the conventional acquisition. And then quantitative metrics, those metrics that relied on signal, it was lower in both of those. However, despite that low signal, which does affect image quality, the Dante CAIP still ended up a lot better. And that's mainly because there was less motion with it. There was less venous signal contamination. There was less arterial signal contamination, less artifacts, and also the lesions were sharper in terms of evaluation. And the main reason for that is probably due to motion and the lack of arterial artifactual signal. And then similarly, when we looked at the Dante space, which is the blood and CSF suppressed technique, it performed better in all qualitative metrics except for motion. Motion was about the same because the scan time was about the same. But in everything else, it performed better. Quantitatively, there was no difference between it and the conventional acquisition. And so in short, the conventional acquisition is intermediate, longer scan time. It has a lot more artifact. It has more arterial and venous flow artifacts, and it has significantly more motion. Dante CAIP is the fastest acquisition at 5 minutes. It has less artifact and it has less SNR also, which somewhat mitigates some of those or contributes maybe a little bit to imaging degradation. And then Dante is the longest acquisition, but it has less artifact and it has better image quality than all the other acquisitions. And sorry, this should say accepted with revisions. So just to share some images with you, here's the pre-contrast. Here's the conventional acquisition. We're looking at the V4 vert, and here along the wall, you can see this thing that looks like an enhancing lesion projecting into the lumen. And that could certainly be confusing to a neuroradiologist as to whether that's wall thickening and thrombus projecting into the lumen or not. And it looks like a real lesion there, but when you look at the blood suppressed technique, that lumen is completely clean, right? And it matches the pre-contrast acquisition. Next, if we look at another case, again, there's actually flow abnormality within the pre-contrast, and that same flow abnormality is seen in the conventional acquisition. When you look at the blood suppressed technique, that goes away. So you can see it even outperforms the pre-contrast acquisition. And here's another example where along the cortical surface, there are all these little enhancing nodules everywhere. And that, you know, in the setting of evaluation of a study, you could potentially say, well, are these little metastatic implants along in the leptomeningeal space? Could this be parenchymal enhancement in the setting of subacute ischemia that may have normalized on diffusion weighted imaging? You know, what are these lesions? But you can see all of those go away once you do blood suppression, because those represent small cortical veins with slow flow. They don't actually represent pathological lesions. So that's an important thing to keep in mind. And in addition, and this is something that's also been shown in other manuscripts, but in looking at aneurysms, here we have a case where this aneurysm involving the MCA trifurcation, when you look at it, you can see that there's an enhancement involving at least 2 walls here of the aneurysm on the conventional acquisition. When you do the accelerated blood suppressed technique, you can see a lot of that enhancement goes away. And this has been established in the literature as in the setting of aneurysms, there is turbulent flow within the aneurysm sac. There can be stagnation within the aneurysm sac, and that leads to this artifactual enhancement. And we'll touch base on that a little more. But again, comparison of the Dante CAIP, the accelerated blood suppressed technique, versus compressed sensing here, which is another acceleration technique, and our conventional acquisition. You can see the blood suppressed accelerated technique is still faster than compressed sensing. And in addition, it does a better job of suppressing that blood signal. Here you see this middle cerebral vein here with pretty good blood suppression. You can see that it's not suppressed on the compressed sensing, and on the conventional acquisition, again, it looks like there's wall enhancement in that branch, and that's also a source of confusion a lot of times. There are a lot of neuroradiologists I've seen who end up confusing enhancing veins, which enhance because of slow flow, compared to, you know, arteries, which, you know, will show less of that slow flow related enhancement. Certainly can be confused for pathology within an artery. So really suppressing blood in all vascular structures is important. And here's that study I mentioned. This is from a French group published in AJNR, where they looked at a different blood suppression technique, and they compared it and conventional acquisitions in aneurysms. And they found that in unruptured aneurysms, 10 aneurysms showed enhancement in a small cohort of like 14 or 15. 10 aneurysms showed enhancement, while on the blood suppressed technique, only 2 showed wall enhancement. And here's an example where you see this MCA aneurysm, you see all this enhancement along the wall, this septum of enhancement, looks like an ugly aneurysm. You would say, man, I'm really concerned that this is unstable. When you do the blood suppressed technique, all that enhancement goes away. So all of it is artifactual. So certainly technique is important in terms of the imaging that you're doing. Another way that we accelerate imaging is this wave-Chi-P acquisition. And what wave-Chi-P represents is another imaging acceleration technique, but we do kind of a corkscrew undersampling. And I know that probably doesn't mean much to the non-radiologist, but it's basically a more efficient way of sampling the imaging to produce better imaging. And so here we see other acceleration techniques up here that are 5 minutes long. You can see this acceleration technique at 5 minutes looks a lot better. And even at 3 minutes, it looks better than the 5-minute acquisitions up here. So again, another approach that can really streamline our efficiency and make it more accessible for everyone who's interested in performing vessel wall imaging. AI is certainly another tool, and it's a tool that we've been looking at. This is with Subtle MR, which is a vendor that where you accelerate imaging and then it does AI reconstruction of imaging to improve the image quality from a reference standard. You can see here's the Dante Chi-P accelerated imaging. Here's the conventional acquisition. And you can see some of these look just as good as the conventional acquisition in terms of image quality. Certainly a range depending on how much denoising you end up doing. Excuse me. And then what we've also been doing is we've been using AI, and this is something that's starting to get adopted by some of the vendors, but it's a paper we published a few years ago in which we used AI to improve the SNR and decrease the noise, but also sharpen the edges of images. And you can see in this example, and this was using a CAN with Tony convolutional layers to deblur it, but you can see in this image, those edges are much sharper. The margins of the artery are sharper, and there's better suppression of CSF and blood signal, secondary to that increased signal within the image. So certainly AI is a pathway for us to continue to push the envelope, push the edges, and improve image quality. So in terms of plaque identification, every paper in the literature uses their own criteria. And so what we decided to do with our prospective data set was develop criteria for evaluation of atherosclerotic plaque through an iterative process to see if we could achieve better agreement. And so we had 19 cases with known atherosclerosis, and these patients who underwent 2 MRI vessel wall imaging scans within a week of each other with a multi-contrast vessel wall imaging protocol. And these are the criteria we created through our iterative review. And when we finally got to the review, in terms of the performance, we found that there was substantial to moderate agreement with most categories, with limited agreement in categories with very few lesions. Specifically, the basilar artery and vertebral artery were relatively limited in terms of number. So those agreement numbers were a little less reliable. And then we looked at interscan reproducibility between the scans performed a week apart. Most of these fell into the moderate agreement category. And this agreement was better than the agreement that existed in a lot of the inter-reader agreement studies that had already been published at the time. So a combination of, establishing reader rules for interpretation, but also image quality can really improve that inter-reader agreement. And I think with heterogeneous protocols, heterogeneous imaging, noise, motion, all those sorts of things, it can certainly affect that. I think as we improve the image quality, that these agreement numbers will continue to go up. So clinical applications is the next thing we're going to talk about. And there are 2 studies we looked at where we looked at plaque detection and luminal assessment, comparing vessel wall imaging relative to time of flight, with DSA for stenosis being the reference standard. And one of the studies, the first one listed there that we published in JMRI not too long ago, we looked at 101 patients with posterior circulation stroke or TIA. 238 of them had, and there were 238 plaques, and vessel wall imaging showed better agreement between DSA and vessel wall imaging. You can see the regression line here relative to the data was much better than DSA relative to time of flight. And vessel wall imaging was also most sensitive and specific for greater than 50 and greater than 70% stenosis relative to time of flight. Another technique, and this is from a French group, where they use MRI in the setting of stroke triage. They have also implemented this really accelerated vessel wall imaging technique. But here's an example of a patient with a punctate infarct involving the right insula. On the MRA, it's really hard to determine, is there an occlusion or not? You could say maybe there's something here, but but it's somewhat limited in terms of evaluation. What they do is this 2-minute or less than 2-minute vessel wall imaging sequence where they do blood suppression. And what ends up happening is at the point of occlusion, everything downstream enhances. So this can be very helpful in terms of depiction of peripheral M2, M3, M4, peripheral PSA or ACA branch occlusions. It can really be helpful in that regard. And here's another example, again, a patient with a left MCA territory infarct here. And on the MRA, the image slice here doesn't really help, but there was maybe a little bit of paucity here. But to find that exact point of occlusion, the vessel wall imaging study can really help. You can see there, and here it is again, where you can see that exact point of occlusion. And you can do various applications where you can overlap that vessel wall enhancement over the MRA. You can overlap the diffusion abnormality over the MRA as well to get more of a comprehensive overview of exactly where the pathology is that could potentially help guide the intervention. And here's just that example where you have that occlusion, that MCA thrombus, and in that setting you have stasis beyond that point of occlusion, which then results in downstream enhancement, even when you use blood suppression techniques. Those blood suppression techniques will be a lot better in terms of slow flow, but in the setting of no flow, occluded flow, there will be enhancement in that setting. So a number of groups have looked at enhancement after intervention. After you go in and you pull out a clot, what do you expect to see? And this was a study from the UCSD group where they looked at 6 post-thrombectomies and 5 controls. And they found that in the thrombectomy group, there was enhancement in the segments that were selected post-intervention. And in the second study from the Toronto group, they looked at 16 patients post-stroke with 6 undergoing stent retriever and 10 undergoing TPA, and they found significantly more wall thickening and enhancement in the thrombectomy cases. And then the third study from a group in Korea where they looked at 29 patients, 15 underwent endovascular therapy and 14 underwent TPA. Again, they found a significantly more concentric enhancement in the setting of endovascular therapy. And that was associated with a more complex procedure with more passes and longer procedures. But in addition, the enhancement was associated with an increased likelihood of hemorrhagic transformation, 58.3% relative to 17.6% in the non-enhancing group. And the odds ratio was 11.2 almost in that group. So we did a survey, and this is right now in submission in AJNR, where we looked at what people were using vessel wall imaging for, how many people were using vessel wall imaging, and a number of other questions in terms of technical utilization. And we got a total of 532 responses. Of those, 55% of the respondents indicated across, academic practices, private practices, internationally, 55% were performing vessel wall imaging. Most common indications were vasculopathy differentiation. Is this vasculitis? Is this RC-VEST? Is this atherosclerosis? Is this something else? Culprit atherosclerotic plaque evaluation, cryptogenic stroke assessment, and aneurysm characterization were in that next category in terms of applications for vessel wall imaging. And next, we asked them, if you're not performing vessel wall imaging, what is the reason why you're not doing it? Why has your practice not adopted it? And the main areas of issue were limited interpretation or technical experience on the part of the radiologist and the radiology group, or clinical applications understanding. So mainly it was and understanding and expertise amongst the radiologists. But in addition, other major categories were lack of radiologist or ordering provider interest in implementation. And an ordering provider understanding was also there. So clearly there's an understanding and education barrier, as well as a technical barrier that are preventing those groups that maybe aren't doing it right now from maybe jumping into this space. And in terms of the respondents that said they did not do it, they indicated that if these challenges were overcome, 55% of the institutions would perform it. So again, that's pretty promising to where, we get 55% say they do it. Of the ones that don't, more than half say they would if they had, a better understanding of the technique, or they had, they could overcome technical barriers and could perform it on their scanners. So that's really on, radiologists such as myself, educating folks on the value, the vendors and others creating more facile tools, better sequences, and also maybe interpretation tools for radiologists to use. And lastly, in terms of ordering provider interest, the groups that were most frequently interested were stroke neurology by far, and then neurosurgery and rheumatology were the next group. And rheumatology, because of the difficulties with vasculitis, they really enter the fray. The interesting thing is that none was the second most common answer. And this again speaks to that gap in understanding of the applications and the value of the technique, which we'll talk a little more about in a second. So next, we're going to talk about cryptogenic stroke, and there's obviously been a lot of studies in this space. And the first study was one that was published not a little bit ago, where they looked at 32 patients with cryptogenic stroke with less than 50% carotid stenosis. And they found that a significant proportion of these patients had complex plaques, AHA type 6 plaques ipsilateral to stroke, while none on the contralateral side. And the most common findings seen were intraplaque hemorrhage, fibrous cap rupture, and intraluminal thrombus, all characteristics that are associated with stroke events. And so that may help in terms of potentially differentiating or squeezing down that cryptogenic stroke number and reducing that. Conversely, on the other side, this is a publication in Stroke from not too long ago, where they looked at 187 stroke patients who underwent mechanical thrombectomy. They had 77 who fell into the cardioembolic category and 46% into the non-cardioembolic category based on modified TOS classification. And what they found was that in terms of fibrin content, the cryptogenic stroke most closely resembled the cardioembolic stroke clots relative to the non-cardioembolic clots. There was a significant difference between the non-cardioembolic and the cryptogenic. And they also found significant differences in RBC and white blood cell content between cryptogenic and non-cardioembolic. So certainly, in that cryptogenic category, vessel wall imaging can certainly help in terms of carotid intracranial, cardiac imaging may be able to help contribute to evaluation of other cryptogenic stroke categories. And this is actually something right now that we're actively investigating with vessel wall MR and cardiac MR as part of one of our new grants that we were just awarded to do a full cardiovascular imaging to really assess source of stroke in that setting. So in terms of stroke risk stratification, we'll talk about that here in a second. But what I will mention is 8 to 10% of ischemic strokes in white populations are secondary to intracranial athero, which certainly isn't a major etiology within that group. But when you look at Chinese populations, that goes up to about 50%. And intracranial athero is likely the most common reason for stroke worldwide. Intracranial athero also is more common in Hispanic and Black populations, and it's likely underestimated in prevalence and association with ischemic stroke overall, as much of the literature relies on stenosis greater than 50% to indicate that association. So, and as we mentioned, a lot of times, the techniques we use for luminal imaging really do underestimate atherosclerotic plaque burden. So the first study I want to talk about was a study from the Toronto group in which they looked at luminal imaging and clinical assessment. And then they included the vessel wall imaging report to determine how that altered the stroke neurologist's diagnosis. And what they found was that vessel wall imaging altered the modified TOAST etiologic classification in 55% of cases in their 205 patient cohort. And they found that the biggest movers were intracranial arteriopathy not otherwise specified, going from 31% to 4%, and intracranial atherosclerosis as an etiology going from 23% to 57%. And an example here from our institution, this is a patient who had multiple TIAs historically, and I believe had presented to other institutions in the Seattle area with workup, but no clear etiology determined. So he came to University of Washington at the time of this right MCA territory infarct. On DSA, intracranial vasculature was normal, extracranial carotid vasculature was normal, Holter monitoring was normal. Everything really came back normal. We decided to do vessel wall imaging. Carotids, extracranial carotids, which are not shown here, were normal. And then intracranially, this carotid terminus here shows wall thickening. It shows an irregular T2 hyperintense band representing fibrous cap and thinning of that fibrous cap in addition to enhancement, characteristics that are associated with vulnerability. And what I will also mention, I didn't share it here, but a CTA was done at the time of initial presentation, and there was a thrombus adherent within this right carotid terminus. And a focal calcification located, a single isolated calcification, which raised our suspicion for intracranial athero, which is what led to the vessel wall imaging eventually. So certainly there was some suspicion of this based on CTA, but vessel wall imaging confirmed it. The patient was started on actually maximal medical therapy and had not had any subsequent stroke events after that. And intracranial athero was presumed to be the etiology of this event. And next, we're going to talk about a study out of China where they looked at embolic stroke of unidentified source, or ESUS, and they looked at 243 ESUS patients and 160 small vessel disease stroke patients. And they found that plaque was significantly more prevalent ipsilateral to the stroke in the ESUS patients relative to the contralateral side, with an odds ratio of 5.25. While in the setting of small vessel strokes, small vessel disease strokes, these patients had plaque equivalency on both sides. Plaque remodeling index, one of the characteristics that we can evaluate on vessel wall imaging, was independently associated with ESUS. And this basically refers to plaque growing outward and achieving higher volume before it results in any stenosis. So we talked a little bit about this, but again, white populations, intracranial athero is considered uncommon, but likely underestimated. In other populations, intracranial athero is very common and is probably the most likely etiology for stroke worldwide. So in terms of that remodeling, as we mentioned, plaques can outwardly remodel and grow to a pretty big volume before they start resulting in any stenosis. And this is the most common kind of mode of remodeling of atherosclerosis. The other component is it can constrictively remodel and result in progressive narrowing. And so in terms of that literature, that ESUS study from China that was published in JACC, you can see that all these curves up here on the ROC analysis with the highest AUC are all have remodeling index within that evaluation. So remodeling index relative to a lot of other metrics in terms of evaluation for ESUS is one of the more accurate measures in terms of determination of association. So here's another study published in which they were looking at positive remodeling. Again, they looked at 42 stroke patients with 137 plaques. And in terms of posterior plaques, they found that there was a larger burden of plaque than there was in anterior circulation. There's also increased remodeling of that posterior circulation plaques relative to the anterior circulation plaques. And that there was an association, or a trend towards association, between that positive remodeling and stroke events in a relatively small cohort. And then in terms of our studies, we looked at 58 patients who presented with stroke who had intracranial athro that we longitudinally followed for up to 48 months. And we found that 20% of these patients experienced recurrent stroke within 11 months. And in terms of the ROC analysis, what we found was that plaque burden at baseline was one of the best predictors in terms of recurrent stroke. And then a combined model certainly outperformed the individual components. But in addition, plaque progression over time was also showed an association with subsequent stroke events, recurrent stroke events, I should say, as you can see on the Kaplan-Meier curve for those with progression versus those without progression. And this is another study where we looked at non-stenotic intracranial plaques, and we used a new tool that we had developed called MoCA, where we can automatically reconstruct arteries and produce both on luminal imaging and vessel wall imaging these straightened arteries and multiplanar reformats where we can look down the barrel of the artery for every single segment. We looked at 25 atherosclerotic patients from our prospectively recruited database with 80 atherosclerotic lesions, and we found that plaques involving the ICA were significantly more likely than other segments to be non-stenotic. 80% of ICA plaques showed a lack of stenosis, but then there was no significant association between stenosis, plaque thickness, or plaque length, indicating that larger plaques do not necessarily result in increased stenosis than smaller plaques. So certainly this is a valuable, vessel wall imaging is valuable because that plaque burden really contributes to association with stroke more than the presence of degree of stenosis in a lot of circumstances. And here's another study just showing that vessel wall imaging does do a better job. And this is those same two studies that we talked about earlier. It really does do a better job of depicting both plaque burden and also degree of stenosis, where you can see time of flight shows basically near occlusion of that vertebral of that basilar artery. On DSA, you can see it's a little more open than it looks on the time of flight, matching what we see on the vessel wall imaging here. But in addition, you can see how big that burden of plaque is, what segments are involved in areas where that plaque is not visualized on the luminal imaging. You can see here there's nothing really at that at that proximal basilar artery. While you can see on the vessel wall, there's a pretty long plaque present there that you would otherwise miss. So certainly value in vessel wall imaging performance in these settings. And again, in terms of plaque location, as we mentioned, plaque burden, stenosis, these are certainly characteristics of atherosclerotic plaques that are worth evaluating. But in addition, the location of a plaque along an MCA artery is also associated with whether there's a development of stroke or not. So location of a plaque along the MCA or along, if you look at the basilar artery, along the posterior wall of the PCA, can contribute to ostial occlusion of those perforators and acute infarct. In terms of most plaques, they're typically along the ventral and inferior portion of the MCA, while plaques that cause these ostial infarcts are most commonly superior and posterior. And also in this setting, those superior located plaques are more likely to be small, despite the fact of the association with stroke. They're more likely to be small than plaques along the inferior wall, which makes sense because these smaller plaques, despite their small size, are more likely to cause symptoms at an earlier stage than a bulky plaque that's not near any ostia. And here's another example. There's a patient with multifocal atherosclerotic disease. You can see a plaque here involving the supraclinoid ICA, but you also see this plaque along the posterior wall of the basilar artery. And interestingly enough, when you look at the T2 weighted imaging, you can see that plaque again, and you see this small branch coming off the posterior wall of the basilar artery, and that was that represented a perforator. But you can also see deeper is that there's this old infarct involving the pons. And so certainly, old infarcts, probably worthwhile looking at that PCA, but similarly on the other end, it's worth, when you see an atherosclerotic plaque along the posterior wall of the basilar artery, look for associated stroke events, and it certainly could raise concern for potential future stroke events without appropriate treatment. Now, plaque enhancement is also a characteristic that has been associated with stroke events. And here we see an enhancing atherosclerotic plaque along the anterior and superior wall of the MCA, here with some luminal stenosis present. And so this is a meta-analysis that was performed out of the Cornell group, where they looked at 8 studies with 295 atherosclerotic lesions that were almost evenly split between symptomatic and asymptomatic. And they found a significant association between plaque enhancement and stroke with an odds ratio of 10.8. And then again, another study from the Toronto group in which they looked at atherosclerotic plaques at various stages post-ischemia, and they looked at the degree of enhancement. And what they found is as you go further out away from the stroke event, especially if you look here, that degree of enhancement really reduces. While the more acute strokes, I shouldn't say acute, but stroke infarcts within the subacute phase, the atherosclerotic plaques associated with those were more likely to show strong enhancement. And in the cases where they had longitudinal imaging on these patients, no plaques showed progressive enhancement in the post-ischemic stage. They were all at their maximal enhancement at the baseline post-stroke imaging. And another study from the Hopkins group in which they looked at plaque enhancement, they found that strong enhancement was significantly associated with culprit plaques with an odds ratio of 34.6. And culprit plaques also showed increased quantitative enhancement. But the main take-home message from this study was non-culprit plaques were never enhancing in their study. And so in that setting, if you see a non-enhancing plaque, you can probably safely say that it's probably not the culprit plaque. The one exception I would make to this rule is that discussion we had earlier about plaques along the superior wall of the MCA or along the posterior wall of the PCA, where inflammation of the plaque may not play as much of a role in terms of stroke events, and osteocclusion may. And that may be a factor in terms of this study where they looked at plaques that were more likely to result in artery embolism as a factor, or large artery occlusion. And this study looked at 78 plaques in 20 stroke patients. So the next study is a study that we published where we looked at 176 patients with 702 plaques stratified into first-time acute stroke, recurrent stroke, or chronic stroke. On the left, you can see the graph showing significant differences in quantitative culprit enhancement between recurrent, first-time, and especially chronic stroke, where you can see the chronic stroke category here. And then performing ROC analysis, we saw that culprit plaque enhancement, plaque burden, and total plaque number all had AUCs greater than 0.7 for association with a recurrent stroke. So those are all factors that contribute to that recurrent stroke risk. So plaque enhancement, the culprit plaque enhancement, plaque burden, and total plaque number. And the next study we want to talk about is a study looking at diabetes control and plaque characteristics. We did this study in 225 diabetic patients with non-diabetic and diabetic patients with atherosclerosis, 958 of which had intracranial plaques. And we found that there were significantly more plaques in those with type 2 diabetes than those without. 4.8 plaques per patient relative to 3.6 in those without diabetes. And those with poorly controlled type 2 diabetes showed significantly higher enhancement grades relative to the well-controlled and the non-diabetic patients, as you can see in both graphs. And the interesting thing is there was a correlation between plaque enhancement, as we mentioned, this is a metric of vulnerability, and also the hemoglobin A1C for these patients. So next we'll talk briefly about fibrous cap assessment. And as we know, the fibrous cap is a layer of connective tissue covering the atherosclerotic plaques. It can thin or rupture, and that's associated with symptoms in the culprit plaque model that was initially described in the circulation papers almost 20 years ago. And in this study, in one study that was published, they looked at 53 plaques from 20 cadavers, and they found that fibrous cap signal is hyperintense on T2 weighted imaging relative to the lipid core, similar to what you see here, this bright T2 signal adjacent to the lumen, this darker component deeper, which is lipid core. And they found that the MRI was a little more than 80% accurate in identifying fibrous cap and other plaque components. So one study that we did, and another study published by a Chinese group, in our study, both of these studies looked at evaluation of the fibrous cap in terms of symptoms. And we did paired assessment of symptomatic and asymptomatic plaques in 18 patients with 42 intracranial plaques. And we found, in terms of this, there were 18 symptomatic plaques and 24 asymptomatic plaques. And in terms of the symptomatic plaques, all of them showed absent, thinned, or disrupted fibrous cap, while the asymptomatic plaques, for the most part, had thick caps. Some of them had absent or thin. So in that setting, if you see a thick cap, you can probably be confident that it is not a culprit plaque. Intraplaque hemorrhage is the next topic, and it's probably the most easily used plaque characteristic that can be used for characterization of vulnerability, maybe because it's binary. Either you see T1 hyperintensity within a plaque or you don't. And this is a study from China in which they looked at symptomatic versus asymptomatic plaques. And they found that in symptomatic plaques, almost 20% showed intraplaque hemorrhage, while 3.2% of the asymptomatic plaques showed intraplaque hemorrhage. A histology study performed by a Chinese group as well found that 30% of symptomatic plaques and 15% of asymptomatic plaques showed intraplaque hemorrhage. So a tighter gap there, certainly, but that was a significant difference as well. And what I will mention about intraplaque hemorrhage, interestingly, is this is much more commonly seen in East Asian populations than it is in Western populations. In my 11 years of performing vessel wall imaging, I've seen maybe a handful of intraplaque hemorrhage studies in all the data that we've collected. While in some of the collaborative studies we've done with China, I want to say maybe three out of 6 or 7 of the first cases that I saw from China all had intraplaque hemorrhage within atherosclerotic plaques. So certainly it's much more common in the setting of plaques in East Asia, which may be genetic, may be related to some other environmental factors, not really clear. So in terms of evaluation of in-stent restenosis, and this is a study that we did in collaboration with China, in which we looked at 64 patients with vessel wall imaging for atherosclerotic assessment and stent placement, and 9 of these patients developed in-stent restenosis relative to the other 55 that did not. And so we compared imaging characteristics, vessel wall imaging characteristics, in terms of what contributed to this. And we found that higher plaque burden, plaque concentricity, and higher enhancement ratios were significantly associated with in-stent restenosis. And so here's an example here: atherosclerotic plaque, concentric enhancement, as we can see, and then the patient was, and this example experienced in-stent restenosis post opening up that artery. Another example here down where there is that initial stenosis, there's that atherosclerotic plaque that's eccentric, shows less enhancement, and upon reopening with a stent, there really isn't any in-stent restenosis development. So next, we're going to talk about differentiation of intracranial vasculopathies, and this is an area where we have done a fair amount of work. The first paper was a stroke paper we published a few years ago, where we looked at vasculitis, atherosclerosis, and RCVS, and looked at characteristics on a multi-contrast protocol that could help differentiate these 3 diseases. And what we found was that there were typical appearances of each disease. With atherosclerosis, typically you have a T2 hyperintense band and a deeper hypointense component that's eccentric. With vasculitis, it's concentric, typically isointense to gray matter. And then RCVS, because it's a constrictive process, you generally really don't see much in terms of wall thickening or involvement. And so this is on T2. When we look at T1 weighted imaging, again, we saw significant differences in terms of the imaging appearance between each of these diseases. And to describe it with vasculitis, you typically see circumferential intense arterial wall enhancement. In atherosclerosis, you see an eccentric lesion that typically outwardly remodels and shows heterogeneous enhancement. And with RCVS, typically there's minimal to no enhancement in this setting. And what I will mention is in terms of RCVS, the pattern of wall involvement from our raters was a little all over the place, where between no wall thickening, concentric and eccentric. And I think the reason for that is because the degree of wall thickening is so little that, you know, a little bit of artifact or even a little bit of a perception, you know, misinterpretation can result in categorizing in all kinds of directions. You know, when you're staring at something for long enough and there's nothing there, eventually you start hallucinating and seeing things. So we did do a subgroup analysis of these patients. We looked at 40 lesions that showed circumferential wall involvement. We found in this setting was T2 weighted imaging really helped differentiate atherosclerosis from everything else, while the intensity of enhancement helped differentiate RCVS from everything else. And here's just an example. This was a patient with a focal stenosis involving the left MCA. And what I'll mention about this patient is this patient had a number of vascular risk factors, who was presumed to have atherosclerosis in the setting of multiple intracranial stenoses. But the patient experienced 3 stroke events in 3 different arterial territories in the span of 6 months. So they came to me and they said, you know, we thought this patient had atherosclerosis, but now we think this patient has vasculitis. Can you do a vessel wall imaging study on this patient? And this was the second study I'd ever done, right? So MRA, you can see that focal stenosis. Vessel wall imaging, you see that concentric enhancement involving that left MCA. And I said, man, that looks like vasculitis. But then you look at the T2 weighted imaging and you see that T2 hyperintense band, deeper hypointensity, looks like atherosclerosis there. I ended up deciding to go on the atherosclerosis side based on the appearance of this lesion on T2 weighted imaging, as well as a couple of other smaller lesions that were present. Patient was treated with maximal medical therapy, and you can see that, I think a third antiplatelet agent was added. I think Celastazole was added. And then you can see over the span of a year, that enhancement reduced, the artery wide opened up, and it's starting to look eccentric, confirming or supporting the idea that this was atherosclerosis. And this patient had no subsequent stroke events after the addition of Celastazole. So in terms of vasculopathy differentiation, there have been a few studies also that have agreed with our findings in terms of vasculitis showing thick wall enhancement that's concentric and persists, while RCVS showing none to mild enhancement that is reversible in a relatively short period of time. Here's one case in which we've seen enhancement in the setting of RCVS, but usually it's very minimal. As we mentioned, minimal to no enhancement. This case was interesting because there was diffuse enhancement throughout the arterial vasculature intracranially. And one caveat I'll give you is typically RCVS doesn't show enhancement. Subarachnoid hemorrhage is inflammatory, right? And it contributes to inflammation. It can contribute to cytokine increase, and that inflammation can contribute to the presence of enhancement. Typically, as I mentioned, it's pretty mild. In this example, it was interesting because it was diffuse. And one thing that helped us differentiate that this was RCVS, obviously the clinical symptoms in the setting of RCVS are very different than a primary angiitis, which helps. But in addition, the enhancement is everywhere. It's affecting segments that are not stenotic as well as those that are stenotic. And in that setting, that's pretty odd for vasculitis. And in addition, there wasn't really much wall thickening throughout. And as we mentioned, RCVS being a vasospastic process, typically you don't see much wall thickening. Vasculitis, you typically will, especially in a patient that has not been treated with steroids. So next, we're going to talk about pattern of involvement. Now, this is the definitions similar to what we talked about plaque characterization or plaque identification. The definitions of concentric versus eccentric are all over the place in the literature. Is it less than 50% wall involvement? Is it less than 100% wall involvement? Is it thickest wall portion 2 times the thinnest wall portion? Or do you just go with the radiologist gestalt of, however the radiologist is feeling that day, representing eccentric versus concentric? And just a few examples. Here's a lesion involving the supraclinoid ICA MCA. And what you see here is the anterior wall is not involved. Maybe 75% of the circumference of the artery is affected, but the anterior wall here isn't. And this one, maybe there's a little gap anteriorly, maybe there's a little gap here. Is this concentric or is this eccentric? Is this atherosclerosis potentially, or is this a vasculitis? And you can see in other segments there clearly was concentric involvement in this patient. So really evaluation, really getting a good gestalt of all the lesions can help. But in addition, on T288 imaging, you can see isointense signal within the wall of that stenotic lesion, supporting the idea that this was vasculitis. And it was a VZV vasculitis in an HIV patient with a CD4 count of less than 20. And here again, is this concentric or eccentric? There's a little bit of wall thickening here that shows a little bit of enhancement there that is only along the superior wall of the MCA. And then this was also a vasculitis patient. Again, you can see diffuse enhancement in the setting of fungal vasculitis with parenchymal invasion here. So certainly you could look at this and say, well, this kind of does look eccentric, but really look at the totality of the lesions and really assess it and come up, and really combine clinical data, imaging data, patterns of multiple lesions, and multi-contrast. Use the T2, use the T1 pre and post to really make the best informed decision. So we mentioned small artery vasculitis earlier, and we mentioned how luminal imaging doesn't really do a great job with it. And this was a study published a while ago in 6 patients with angiographically negative primary meningitis of the CNS. What they found was that 5 out of 6 patients had enhancement and enlargement along the perivascular space. And in these patients, when they were treated with steroids, all showed marked improvement or resolution of that perivascular enhancement and enlargement. So steroids definitely will melt away small artery angioitis pretty quickly. And the way I like to describe it is, in the setting of, small artery vasculitis, the reason why it melts away so quickly is because what you're seeing is you're not only seeing the inflammation within the arterial wall, you're seeing the spillover of inflammation to the perivascular soft tissues. So it's not just the wall that you're seeing, similar to, you think about it with luminal imaging, what you're looking for is that atom bomb. You're looking for the physical bomb, the stenosis of the arteries, and in perforators, that's really tough to see. With vessel wall imaging, what you're looking for is the mushroom cloud. When that thing explodes and the inflammation spills over into the adjacent tissue, you're looking for that inflammation, not the actual stenosis of that tiny perforate. And in that setting, because of that, vessel wall imaging can help in detecting small artery angioitis in its active phase. Once you start treating with steroids and that perivascular inflammation goes away, at that point, the mushroom cloud disappears and it becomes very difficult to assess. And that's going to segue into the next study I'm going to talk about, where this was a study from Germany in which they looked at 31 patients with primary meningitis of the CNS. And these patients had either histology or clinical criteria for diagnosis. Patients were imaged on both 1.5 and 3T scanners, not clear as to who was imaged on what and how many, but they did a little analysis and they found that in patients who had a positive biopsy, typically the MRA and DSA were negative for vasculitis, including vessel wall MR. In those patients with a negative biopsy or no biopsy performed, generally the MRA and DSA were positive. And so it's an interesting study. Basically what it's saying is biopsy those patients that are imaging negative because they're probably small artery angioitis. You obviously don't need to biopsy the large artery abnormalities, but if they're positive in that setting, that's pretty good in terms of diagnosis of primary meningitis of the CNS. But there are a number of questions here. What protocols did they use? Were the biopsies targeted in terms of assessment? What's the experience of vessel wall imaging of the evaluators of these studies, the initial reporters? And also a key question is, had these patients undergone steroid therapy before their imaging? And as we mentioned, for the small artery vasculitis, while they say very few of them were positive, in that setting, if you treated with steroids and you imaged, then those are going to be negative, even if they would have been positive at baseline. And these are questions that weren't answered in the paper, certainly things that could have been brought up. but some caveats and some potential future directions in terms of evaluating this. And here's an example I wanted to share of a patient with who subsequently underwent biopsy and was proven to have primary angiitis. At baseline, the patient had presented to us with multiple stroke events at an outside institution. They suspected vasculitis but didn't have confirmation of diagnosis, and they started him empirically on steroid therapy. When presented to us, you can see there's no luminal stenosis here, but you can see despite those steroids, those large arteries are still enhancing, and there's circumferential enhancement involving multiple segments, supporting that idea that this was vasculitis. And next, we're going to talk about some added value studies that we performed. The first one was published in Stroke a few years ago, where we looked at non-occlusive vasculopathies. And we looked at consecutive patients with luminal stenosis and clinically defined vasculopathies. We had 2 raters evaluate disease on luminal imaging, and after a 6-week washout, these reviewers reviewed the luminal imaging plus vessel wall imaging. We found that there was significant improvement in diagnostic accuracy with the inclusion of vessel wall imaging, with sensitivity or with accuracy going from 30% to close to 90% or above 90%, depending on whether you were looking at per lesion or per patient assessment. And what we also found was that the pattern of involvement, the association with atherosclerosis with eccentric involvement was much higher with the vessel wall imaging than it was with luminal imaging. And the inter-reader agreement for diagnosis, when compared to some of our prior literature, was much higher with vessel wall imaging as compared to with luminal imaging. And what we found also was that there was a significant correlation in pattern of disease involvement and diagnosis, eccentricity, but vessel wall imaging had a significantly higher kappa of 0.69 as compared to luminal imaging, which had a kappa of 0.18. In addition, generally with atherosclerosis, we typically say it's more likely to involve proximal branches, while vasculitis and RCVS are more likely to involve peripheral branches. But with the exclusion of the cavernous carotid segment, there is no significant association in the segment of involvement and the disease diagnosis. So that kind of dispels a lot of the characteristics that we typically use for diagnosis on luminal imaging: eccentricity, proximity, and shows that vessel wall imaging outperforms those, and in general does better in terms of disease differentiation. We did the same thing with Moya-Moya vasculopathy, and we found that including vessel wall imaging significantly improved diagnostic accuracy compared to luminal imaging alone. Again, 80 to 90% with vessel wall imaging as compared to 30% without it. And here again, Moya-Moya disease typically does not show much wall thickening because it is a neoproliferative process with inward remodeling. There's not much enhancement there. Atherosclerosis, outward remodeling, eccentric enhancement. Vasculitis, everything enhances that's affected. There are some studies in the literature that indicate that there is enhancement in Moya-Moya disease, and this was a study from Korea, where they found that Moya-Moya disease did enhance, but it did not outwardly remodel, which is different than atherosclerosis, which does outwardly remodel. And we have seen a couple cases like this. Here's one example of a case with enhancement. Again, no wall thickening, no juxtaluminal T2 hyperintense band representing fibrous cap, no lipid core, supporting the idea that this was idiopathic Moya-Moya disease. And this is supported by some literature that indicates that there, on histology, there is a transient stage of inflammation within the walls of Moya-Moya disease patients. So in terms of differentiation of vasculopathies, there really is no contest between vessel wall imaging and luminal imaging. And next, we're going to quickly talk about aneurysms. First, this is a study that we published not too long ago, where we looked at unruptured intracranial aneurysms, and we stratified them into low phases score versus high phases score. And we determined that there were significant associations with maximum intensity of enhancement of the aneurysm wall and the phases classification. In addition, there's a trend towards significance for the number of quadrants with enhancement. And we also looked at wall thinning, and there was higher wall thinning, higher amounts of wall thinning seen in the in the higher phases category, but this was not a significant relationship. Another study that we looked at where we compared asymptomatic aneurysms, symptomatic aneurysms in the unruptured category relative to each other, with symptomatic falling into sentinel headaches and oculomotor nerve palsy. And our total population was 273 aneurysms in 225 patients. And in terms of this evaluation, we did quantitative and qualitative assessment of these aneurysms, and we found that the combination of qualitative and quantitative aneurysm wall enhancement outperformed a number of metrics in terms of evaluation for vulnerability on the AUC, on the ROC analysis and the AUC. And we found that there was a lot more enhancement seen in those aneurysms that were symptomatic, secondary sentinel headache or oculomotor nerve palsy, than there was in the asymptomatic aneurysms. And here's just an example of a large aneurysm coming off the ACOM that shows a lot of wall enhancement there. And here's an example of wall thinning, or what we determined to be wall thinning in our study, where along the posterior wall there is an area of discontinuity of the wall. And this is a study from the Mayo Group where they did a systematic review and meta-analysis looking at 6 studies with 505 aneurysms. They found significant correlations between wall enhancement and the likelihood of instability. But what they found, and the key take-home point, was the absence of wall enhancement is a strong predictor for aneurysm stability. So if you don't see any enhancement of that aneurysm, more than likely it's a stable aneurysm. And in the setting of a ruptured aneurysm, it's probably not the one that was in the wrong. And here's an example of a patient with diffuse basilar subarachnoid hemorrhage. On MRA, you can see that there's a basilar artery aneurysm, and then there's a supraclinoid ICA aneurysm. And the question is, which one ruptured? You know, based on morphology, that supraclinoid ICA aneurysm has irregularity and it looks a little concerning, but at the same time, you know, based on data, things like phases, certainly basilar artery is more of a concerning aneurysm in terms of rupture. So which one are we going with? When we did vessel wall imaging, you could see that there was enhancement of that basilar artery aneurysm wall circumferentially, no enhancement of that supraclinoid ICA aneurysm. So this was determined to be the ruptured aneurysm. It was subsequently treated, and the patient did well. And next case, this patient has basilar subarachnoid hemorrhage again. On CTA, there's a little protrusion from the carotid terminus here, and it looked like there's a little branch coming off of it. So the neurosurgeon said, we think this is an infundibulum. We don't think it's an aneurysm, but we want to do vessel wall imaging to look for dissection. So we did vessel wall imaging, and here's that little protrusion there on the pre-contrast. On the post-contrast, I looked at it, I said, there's a dome of enhancement there. Infundibula don't show this dome of enhancement. So I called up our neurosurgeon and told him, I think this is a ruptured aneurysm. They went in and did DSA, and you can see that that was an aneurysm there off the super aspect of the carotid terminus. And that appearance of branches coming off it was actually artifactual venous channels coursing in close proximity to it. So it was purely artifact. And another study I want to talk about quickly is vessel wall imaging's value in terms of predicting vasospasm. We looked at 9 unruptured and 22 ruptured aneurysms with vessel wall imaging immediately after treatment. And we found that enhancing segments were more frequent in ruptured aneurysms, likely due to that blood component. But also in looking at each segment individually, there's a significant association between branch enhancement and the subsequent development of vasospasm when controlling for hemorrhage grade, with an odds ratio of 3.9. And here's an example, basilar subarachnoid hemorrhage, pica aneurysm here, baseline DSA looks normal here in this MCA branch. What we did see was that there was circumferential wall enhancement of that right MCA. Subsequently, vasospasm develops within that segment, and associated with that area of stenosis is right here. And then we also found that balloon-assisted or stent-assisted coiling was associated with enhancement of the segment that's selected for that treatment with an odds ratio of 7.4. And here's another interesting case. This patient had minimal blood within a sulcus, a modified fissure of 1, and a large ACOM aneurysm that had ruptured. And then at baseline here, the MRA looked normal, right? But then we did vessel wall imaging. You can see enhancement of that supraclinoid ICA. Subsequently, vasospasm did develop, and you can see that stenosis of that supraclinoid ICA. In this example, anecdotally, it did predict the likelihood of vasospasm better than the modified Fisher grade. I know for the modified Fisher score, there's not a lot of difference between different grades and likelihood of vasospasm development, but in this setting, it was certainly helpful. So in summary, vessel wall imaging techniques are improving, making it more accessible and less artifact prone, but improving those techniques, improving automated AI processes, improving interpretation and education certainly are important for this to further impact the field. And then vessel wall imaging has a potential in vasculopathy differentiation and characterization, both in the setting of stroke and in other vasculopathies to guide appropriate therapy. And really continued progress is needed, both in atherosclerosis, aneurysms, as well as in other diseases, to further our ability to assess and really know what we're looking at. Thank you so much, and just a little bit about my funding and my collaborators.
Thank you very much, Professor. It was an amazing talk, certainly humbling, seeing how much we don't know about this and how it could help in our specialty. So first of all, Dr. McDougall, do you have any comments or questions before I start?
I just want to echo that that's incredibly helpful education for me. We are, I think seeing the beginning of something that's really is going to change our practice and really is going to be part of our everyday life, especially in the stroke centers, and the work on the stroke and the identifying the active plaques and the intracranial atherosclerosis is very impressive, and you can really just see how helpful that's going to be and how much we've been working in the dark, differentiating vasculitis from the cryptogenic strokes and things. So extremely interesting work, and I guess from a kind of practical aspect, the real question is how you see this rolling out and getting incorporated into everyday use. You talked a little bit about the barriers to adoption and your survey of why practitioners, aren't using this on a more routine basis, because it sure looks like that's the direction we're going to head for. You can imagine a very high percentage of stroke patients benefiting from the vessel wall imaging. What gets us there in terms of adaptation, and what are the barriers in terms of cost, or is it really just our own initiative?
Yeah, I think that's a great question. And it's certainly a question that's been on the minds of radiologists and societies, especially those focused on vascular imaging and vessel wall imaging. And I think a few areas. Education is certainly important. Educating the value, both in terms of, ordering providers, neurosurgeons, neurologists, rheumatologists, everyone else who may order these, and also radiologists in terms of value. I think another gap is interpretation. And the interesting thing is, even in my group at University of Washington, we had been doing it for 10 years, but there still was a gap in terms of understanding exactly what to do and what to say and what something means. And so I think overcoming those gaps is very important. I think improved tools, improved sequences that can be run and are a little less either faster or more resistant to motion, because as we know, stroke patients aren't always the most cooperative patients for good reason. Right. And then also on the post-imaging side, processing tools and AI tools to enhance the imaging and enhance the evaluation, as well as potentially extract quantitative metrics or other metrics that can help with diagnosis, would be really beneficial. And that's really, people developing those tools, vendor engagement, and having the vendors at the table contributing solutions and coming up with solutions, and maybe responding to the needs of practitioners would certainly go a long way. But I will tell you, when I started this in 2012, it's come a long way since then.
Right. So the the actual cost of adopting this in your magnet and the barriers in terms of the existing magnets, is that an issue?
If you have a relatively modern magnet, modern scanner, you should have the ability to do this relatively easily, right? Some vendors have a sequence that comes out of the box. A lot of the vendors, the MR makers, you have to adapt that sequence to get it to the point to where where you can make it better, right? And I think a lot of the people that do this actively have done that. I'm sure you know Bruce Wasserman from
Yes.
Hopkins, but he's certainly done that. I've done that at University of Washington. There are other people that have certainly optimized those protocols to make them perform much better. But once you have that sequence, it's just running it and getting used to reading it and really knowing what you're looking at.
Thank you. Matthias, do you want to?
Yeah, I have many questions. So first of all, we have questions about different topics. About carotid stenosis, do you think vessel wall imaging could help us classify the patients according to risk in, for example, those patients with less than 50% stenosis? Do you think we can just create like some kind of algorithm or protocol based on this?
I definitely think so. I think there is value in the setting of performing carotid imaging in those categories. I think for stratifying risk and for potentially, the thing is medical management has improved so much that the baseline has really changed in terms of carotid disease, right? And the threshold to do an endarterectomy or to do a stent has really changed. But I certainly do think that carotid vessel wall imaging can much better inform what we're looking at, the association of risk associated with that lesion, and definitely better guide management.
Okay. Then, do you think there is any application for vessel wall imaging in AVMs? For example, there is a paper from Krings.
Yeah.
Showing enhancement in AVMs and correlations with some biological. So do you have any comments on that?
So I know the Toronto and Yale guys have been looking at that. I haven't done vessel wall imaging in AVMs. I've never gotten that request come my way. Maybe I'll have to talk to Lewis and, or have a conversation with Lewis and Mike, because I'm still involved in the vessel wall imaging there. But I do think there's value. I know the Yale guys, I've seen them share cases where they're looking at aneurysms within the AVM and it helping in terms of evaluation of that aneurysm. But beyond that, my experience is fairly limited in that setting.
And regarding aneurysms, applications of VWI for aneurysms, first question is, what are the main, if you have to summarize the VWI features of unstable, right, of instability, and there any study suggesting any association between these features and predicting like rupture?
Yes, so a lot of work is being done in this space, and we've certainly done a fair amount of work. I think quantitative enhancement shows an association between vulnerable aneurysms versus what's considered to be stable aneurysm versus ruptured aneurysms, right? And also qualitative enhancement as well, but quantitative may be a little better in that regard. Number two is in that setting, there's not really a reference standard for vulnerability. We just have our vulnerability scores. So it's kind of beating around the drain, but not actually going down the drain and really hitting that gold standard outcome of rupture. The other thing is there has been associations with, aneurysm enhancement, wall enhancement, and a surrogate marker for rupture, which is growth, aneurysm growth, and that's certainly been shown. But I think one of the challenges is, as we talked about, with that flow artifact that exists with a lot of the older literature in aneurysms and vessel wall imaging, really to be able to see as we start using those blood suppression techniques, does that enhancement hold up or not? Is that enhancement secondary to slow flow along the aneurysm walls? And can we maybe tease that signal out a little more with these blood suppression techniques that show true enhancement of the wall and true inflammation, that can potentially tease out those that are stable but enhancing versus those that are unstable and enhancing. And that may help granulate what we're looking at a little more.
Okay. Then we have seen a few papers on the use of VWI in the identification of the bleeding aneurysm in the setting of multiple aneurysms.
Yeah.
What is your experience with that?
Yeah, so I shared that case that we had, and I know there's a paper from Charles Matuk in the Yale group in regards to multiple intracranial aneurysms, and I certainly think there's value there. If there's more than one enhancing aneurysm, either due to more than one at baseline enhancing, and then one rupturing, certainly that confounds it. The other thing is, as I mentioned, subarachnoid hemorrhage is inflammatory. While usually it won't specifically target just the aneurysms, it'll probably result in enhancement in multiple locations, especially in closest proximity to the ruptured aneurysm. But certainly that can confound the case. But I think if you do a study, it's valuable to do the study. Look at the aneurysms. If one is enhancing and the rest aren't, I think it's certainly informative. But if multiple aneurysms are enhancing, it complicates the picture a little more.
Okay. In the setting of intracranial vasculopathy, or specifically atherosclerosis, do you think we could predict which patients are going to have a good response to intracranial stents or to maximum medical therapy?
I think stenting, we are moving in that direction. We're gathering data. I think we've published 2 papers on vessel wall imaging and in-stent restenosis. And I mentioned some of the characteristics that are associated with in-stent restenosis. So I think we're moving towards maybe having better data there. In terms of response to maximal medical therapy, that was really our target of one of our RO1s, was to determine plaque characteristics that are associated with longitudinal improvement in risk, reduced risk of stroke, but also imaging appearance of plaque, and creating a score that would stratify that risk. And we're still working on that. Hopefully we'll have some data to support that, but certainly that's a very active area of research, is determining at baseline which plaques are going to respond to treatment, which plaques are not, which plaques, may be consideration for other treatment approaches. Maybe not, maybe in the future, as we gather more data, more studies are done, maybe some of those treatments can become standard of care.
Okay, this is just a personal idea. Do you think in patients with many risk factors for aneurysm formation or subarachnoid, maybe we can detect some kind of defect on the wall of the vessels that could predict formation of aneurysms, like pre-aneurysmal?
So you're saying maybe the patient has one aneurysm, you do a vessel wall MR,
or we're just doing like screening for the family of somebody with severe, like familial aneurysm or PCKD or whatever.
Yeah,
you could predict.
I think it's a great idea. I think it would be great to be able to evaluate that. I think it would be. We haven't done that. I haven't seen anyone looking at that. But I think it would be really interesting to look and see, could we tease out areas where there's wall enhancement, maybe some potentially maybe with quantitative metrics, areas where the wall is a little thinner. That sort of thing, as our techniques improve and as the post-processing improves, see that and see if there's any correlation with longitudinal assessment in these patients, where they develop aneurysms and what associations there are. I think that's a really interesting direction.
There is a question from the chat, I think from a radiologist specifically, is asking what lesion might be too distal, because he marks like a challenge of signal to noise.
Yeah, so signal to noise is certainly a challenge, and as those arteries get really small, visualization of them can be challenging. I think in the setting of say an inflammatory vasculopathy like primary angiitis, like a small artery vasculitis, a lot of times we will see that enhancement in that setting as subcortical enhancement because of inflammation spillover. in that setting of those tiny branches, it may be difficult to determine and ascertain the pattern of wall involvement. But in that setting of inflammation and spillover, you can still certainly see that. I've seen mycotic aneurysms as well involving fourth order branches that show enhancement. So certainly I think pathology can be seen out there, but just in terms of the way that we typically evaluate it more proximally is a little more limited peripherally, but you can still see disease.
Okay, there is a question from Juan Vivanco Suarez. He thanks you for the talk. He asked, what is your opinion on 7 Tesla MRI for intracranial atherosclerotic disease and aneurysm risk?
Yeah, so I have not been involved in atherosclerosis assessment on 7T scanners, though I have collaborated with some groups on aneurysm assessment at 7T. What I will say is 7T, and there are groups that have done a lot of this. I think the Minnesota group, when Qureshi was still there, had done some work on atherosclerotic plaques and ex vivo imaging. The Utrecht group with Jura and Hendrickson has done a lot of imaging at 7T. And I think there's a lot of value there. I think what they've indicated in the literature is that at 7T, you certainly get better SNR. They are able to detect and depict more lesions than they are at 3T. And I think in terms of plaque composition, SNR can play a factor in terms of masking some lesion characteristics. I think certainly there is the potential to better visualize those with the 7T, but that literature still is forthcoming.
Okay, I have no more questions.
Matthias, I see Dan Sasando's hand up. Are we able to access? He's in the attendee rather than the.
Yeah.
Are we able to get access to him?
Let me see. 1 minute. Maybe.
I know we're at time.
Yeah. Corey, once. Could you please add Dr. Susanto to the panelist list? Maybe.
Do what with his?
Dr. Susanto, one of our radiologists, the head, is on the would like to. No, yeah, to unmute his microphone or put him on panelist. Thank you.
Are we able to do that? No. Oh, wait, there.
Oh, hi.
There he is. Hey, Dan.
I'm one of the radiologists here at neuroradiologists here at Swedish Cherry Hill, and perhaps I'll share my experience in attempting to do vessel wall imaging. Thank you very much for the talk. First, so we have 3 scanners, coming from the oldest software to the newest software. So 2D versus 3D. Certainly, I've seen that 3D is much easier to implement with the newest scanner with AI help in accelerating the acquisition. I find it, in the initial implementation with 2D imaging, certainly difficult because then individual radiology involvement has to be at the scanner prescribing the sequences, the multiplanar oblique versus conventional orthogonal views of the vessel in question. 3D certainly more practical and allows for more protocolized acquisition. The interesting on CSF pulsation, we're primarily a lot of GE scanners, not familiar with too much with space or KIPI acceleration. But do you find that have you seen acceptable images coming out from Cube imaging or MSDE technique from GE side?
Yeah. Well, nice to meet you, Daniel, and thank you for the question and for sharing your experience. I think GE is probably the platform I have the least experience with in terms of SOL imaging. For us at Harborview, the primary scanner we performed imaging on was our 3T Prisma. And that's where I think most of the images that you saw were from, because it was our primary neurovascular hospital. And then I also had experience with Philips at University of Washington Medical Center on our Ingenia platform. So I think in terms of those techniques, I think I've seen a lot of value. GE, I don't know. I know the Toronto guys for a while were struggling with their 3T GE protocols. But I do know some people are producing pretty good imaging on it. I know the UCSF guys have been using the GE platform for a while for vessel wall imaging. As I think Mayo guys mostly are focused on Siemens, but I think they do a little bit of GE scanning too. I think the CAIP is great for acceleration and reducing motion. We found a significant improvement in terms of motion with CAIP. I do think the portion that's caused the bigger impact is on the Siemens platform, what's called Restore, and on the Philips platform, what's called Anti-Drive for CSF suppression, and that's something that the Hopkins group published on. And then beyond that, the Dante for blood suppression. I think those really made big differences in terms of image quality for us. Just making sure that artifact isn't there. I mean, I shared a few examples in the lecture, but in the 89 cases we reviewed, almost every case had some sort of flow artifact that could be confused for a pathologic lesion on the conventional acquisition. So I think blood suppression is a pretty important thing. And MSDE, so it's a good question in terms of MSDE. I tried MSDE on the Philips platform and it didn't work well for me. The problem with MSDE, and for those that don't know, MSDE stands for motion sensitized driven equilibrium. But with MSDE, I think the thing is it does reduce signal, and there is T2 decay there, so you don't get quite as good a T1 signal within your images. But on Philips, it just didn't work well at all. It made the images uninterpretable. I've heard from people that on the Siemens platform, MSDE works a lot better, but I've never used it on the Siemens platform. But this is from physicists, so it may hold more promise there. And in that setting, potentially it could be good on the GE platform. I'm not really sure, but I think it's not homogeneous in terms of the application of these techniques and the quality with the various vendors.
Matthias, is it okay for me to ask another question? I don't want to ask out of turn.
Sure, please.
So what in your routine sort of protocol, I'm guessing, do you obtain, sagittal 3D whole head, Restore, Dante prep, 3D imaging? What should we shooting for in terms of time? And what is your sort of best case scenario in terms of acquisition time?
Yeah. So what I've been doing is, in terms of our imaging, first we do the time of flight MRA as part of the protocol. If we're doing a dedicated vessel wall protocol, we do time of flight MRA. We do T1 pre, and typically I do the T1 pre as a CAIP because it is the fastest acquisition we have at 5 minutes. We do a post-contrast MRA to be able to better tease out, whether it's, true occlusion or not from the time of flight in the setting of vasculopathy to get better evaluation of the lumen. And immediately post-contrast, we do the T2, the 3D T2 space, which is about a 5 or 6 minute acquisition. And that gives us time for the contrast to kind of settle in. And from there, we do 2 T1 posts. We do a Dante CAIP T1 post and then a conventional T1 post. And initially it started off because I wanted to see the difference. But then what I found is that sometimes patients may have motion with one and not the other. And so that can improve assessment in that setting. And in addition, just in terms of comparison, I found value in terms of comparison. If you don't have time for that, you could do just a Dante space, which is, if you have access to Dante, or an MSDE, variable refocusing flip angle sequence. that'll provide really what you need at baseline. So it really depends on how much time you have and what you're willing to do and what you find to be valuable.
Okay, so you do both accelerated post-contrast T1 and non-accelerated post-contrast T1. Yeah, thank you.
Yeah, and our acquisition resolution is 0.56 isotropic.
Yep, that's the other key.
Yeah, I mean, certainly you want high resolution, but at the same time you don't want to go so low that your SNR is all gone.
Mm-hmm.
And in that setting, the imaging can really look degraded.
Thank you.
Okay, if we have no more questions, I want to thank Dr. Mossa-Basha for being with us. It was amazing for everybody and it's extremely helpful.
Yeah. Well, thank
Thanks
you.
so much. Really appreciate it.
I really appreciate the opportunity to talk to you guys.
Thank you very
Thank
much.
you.
Have a great
Thank
day.
you. Have a good one.
Bye-bye now.